Today, we're discussing a healthcare epidemic with far-reaching consequences. That, of course, is opioid addiction. According to the CDC, more than 130 Americans die every day from opioid overdoses. On today's show, we're going to talk about this growing problem with Dr. Gary Malone. He's a psychiatrist on the medical staff at Texas Health Recovery and Wellness Center. We'll discuss how this crisis began and what's being done to help those who have been affected by addiction. That's coming up next.
Welcome to the Wellbeing DFW podcast. Each week, Scott Sams will cover a different topic on improving health and well-being in our North Texas communities. He will host interviews with physicians on the medical staff of Texas Health Hospitals.
I'm Scott Sams. Thanks for joining us today. I have a staggering statistic for you from the CDC. About 20 years ago, 8,000 people died per year from opioid overdose. In 2017, that number ballooned to more than 47,000, and that's just in the U.S. It's no wonder the Department of Health and Human Services declared a nationwide public health emergency around the opioid crisis. The big question is, what happened, and how have things gotten so bad with this addictive drug? Our next guest will help shed a light on this. He is Dr. Gary Malone. He's been in practice for more than 20 years with a specialization in addiction psychiatry. We're going to talk with him about opioids and some options for treating addiction. Doctor, thanks for being with us today.
Thank you for having me here.
We have this in our family. We have had someone in my family that became addicted to opioids. It's a terrible, terrible thing.
Well, yes, and actually the numbers you just reported are true. I started medical school 44 years ago this month, and have always been interested in addiction. It runs in my family. I grew up around addictions.
Let's start at the beginning. What is an opioid, and why is it so good at stopping pain?
We have opioid receptors throughout the brain and spinal cord. They involve both dopamine and serotonin receptors. Now, all you need to know is dopamine involves pleasure, serotonin involves excitement and arousal. Any person takes an opioid, initially you'll be a little stimulating. At the same time, if you take a higher dose, you get pain relief, have a state of well-being. It's called the oceanic bliss. It's like you're sitting on the beach with your mom on a raft on a sunny day. Mm-hmm. It's just a wonderful feeling. The other thing that happens is your primary pleasure centers, this is not that technical, it's your nucleus accumbens, ventral tegmental nucleus, and your septal nucleus, your primary pleasure center involved in eating, sleeping, and sex, is inundated by opiates, and it feels great. If you have a genetic vulnerability, you're addicted in 5 days.
In my extended family, there is a history of opioid addiction. I had pleurisy back in the early 2000s, and I had to take oxycodone for pain, because if you've ever had pleurisy, it's like a knife every time you breathe. I was allergic to it, so I had to take Benadryl on top of that. And I did that for about a month and a half. I wasn't addicted at all. As a matter of fact, I wanted to get off it as fast as I could. But just within an extended family, somebody can get addicted in 5 days?
Well, yes, and you have to realize, too, that probably in your extended family, not everyone has the same eye color. No one has the same skin tone.
Right.
The Mayo Clinic has isolated down to about 5 gene clusters. These are narrow illnesses. Mm-hmm. If you have one of these gene clusters, number one, your tolerance is too high. You hear about someone who can drink people under the table.
Right.
It was a badge of honor in high school.
Right.
After that, it's just a burden.
Yeah.
You have high tolerance. Number two is your pleasure centers, particularly your septal nucleus, overreacts. So the stories I hear is you're in high school, you go out with your buddies, you have 3 beers, everybody throws up, you don't throw up, you have 6 beers, you feel wonderful.
Yeah.
You're in bliss. Or the first time you take cocaine or first time you take an OxyContin. You go, what is this? I've got to have that.
Yeah.
And the first one's the best feeling. You'll continue to chase that.
Yeah.
But that's the genetics of it. Now, you always break down some ethnicity, too.
Okay.
And psychiatry is getting better at that part.
Okay.
The 3 highest risk ethnic groups, one is Central Europe, that's Polish, West German, and Czech. I'm half Czech. Scott Irish, how many billion of Scott Irish around here?
Right.
And Native American Hispanic.
Okay.
So where I grew up in West Texas, that's everybody.
Everybody. And that's why the addiction rate was so high there.
Oh, yes, exactly. Also, believe it or not, connected with risk-taking and pleasure-seeking. Who came to America, who came to Texas? We're higher than the 8% here. I've known since I was young. I had people die in my family, and I asked my dad what was happening to these people. They were like eating from within.
Yeah.
Who said that, well, they have alcoholism. You have it too. So how do I not die? I said, don't drink.
Yeah.
Good advice.
Yeah.
But these genetics, once you have them, you can get tested at 103 and you're still there and do not go away.
Let's talk about recreational drugs. Many people are introduced to them socially, in school, college, after college. Is it true with opioids as well? I mean, is it a gateway? It can't be really a gateway drug, can it?
It is now. I remember being in college, and I never saw an opiate the whole time I was there. We saw a lot of alcohol, some marijuana, and occasional stimulant. But now I talk to the kids, the adolescent, young adults, college-age students. Opiates appear routinely at their parties. It'll be one of the choices that's there. And so they get introduced pretty early. Our young adults swim in a sea of drugs and alcohol, and the ones with the vulnerability come out with a problem, but they get introduced very young.
I know that you, doctor, have seen many patients that are addicted to drugs, this drug in particular, opioids. Are there different kinds of opioids that seem more addictive than others?
The pill form is highly addictive. It's not as addictive as the Chinese fentanyl and carfentanil. Those are the most addictive. The black tar heroin coming across the border right now is extremely addictive. Those are the ones that take you close to death, and that's the high people are looking for. Right before you die, you get the blissful high.
Is there a certain kind of opiate that you see more of in working with people who are addicted?
It's all three in my practice. Now, at UT Southwestern, they see more of the heroin. Here in my practice, I see more of prescription medicines from doctors and also the drugs from China.
Doctor, it seems that everyone knows someone or knows of someone who's battled addiction. How prevalent is opioid addiction?
Addictions are roughly 8%. They were 6% most of my career has gone up because the substances were more powerful. Opioids in areas where they are prevalent is up to 20%. So to answer that question is somewhere between 8 and 20, but that tells you how common they are now.
What kinds of treatment options are there now for opiate addictions?
You must start by abstinence. You have a genetically determined progressive fatal illness. The only treatment is abstinence. You must be detoxified. We then must get on a regime of medicines to relieve pain without compounding the problem. We must teach you different pain management techniques that you can learn about how to take care of your body, hypnosis, and teach you lifestyle changes. So you pay attention to your body instead of using your body as a vehicle to overwork and take care of other people. You have to pay attention to yourself, have self-love.
Some would say a simple fix would be for physicians to just cut back on the opioids. Is that true? Is that a possibility?
Unless you have chronic pain, then what? Physicians must be educated on what to do with pain patients. Don't just give a pill, that doesn't work, give a patch, that doesn't work, give a pump, that doesn't work, they're dead. You must know the options for pain management, and doctors are not trained in that right now. And we're a long way from training them.
If someone is, say, a recovering alcoholic, they generally stay clear of alcohol. They've been sober for a long time. If you become addicted to opioids and are recovering from that addiction, does that mean you have to steer clear of the opioids for the rest of your life?
Well, let's say steer clear. What it means is this. Acute pain is bad for everybody. If you break your leg or you have an abscessed tooth, you take opioids for 3 to 5 days. But if you have the genetic risk for addiction, you cannot take these medicines over a period of time. You'll get addicted in 5 days. No one should take these medicines for an extended period. You take opiates for 2 months, you get cognitive slowing, you get depression, and it quits covering the pain. You're just taking the medicines. You're just addicted to it. You have to learn the other techniques.
Are you seeing any changes within health systems to offer alternatives to opioid usage for pain relief?
So they're trying to put out the word that there are alternatives. I think doctors are resistant to this. Even the psychiatrists I know go, I don't like this, I don't touch it. You know, someone else get the pain medicines because they don't know what they're doing when they get into it. We have to go back and re-educate medical students and tell people they're going to give these medicines or treat pain. They have to know what they're doing. Someone
listening to us right now, man, woman, young, old, is dealing with opioid addiction themselves or within their family or within their circle of friends. What do you tell them?
Number one, get education. You can go to the National Institute of Drug Abuse, National Institute of Health websites. You can get assessments. Now, THR is very good at giving assessments. If you call up and say, hey, look, my son has an issue with addiction, you can bring him in. They don't charge you. Do an assessment. And they'll say, this person with these issues should be at this level of care. So you then know. you know what the person has and what the treatment is, which, by the way, is tremendously relieving anxiety.
I would imagine.
That this is an illness, an entity, and there's a fix. Sometimes you can't get the person to do the fix. Sometimes the person tries and fails. We also recommend if you have a family member, we support going people in Alcoholics Anonymous, Narcotics Anonymous, or something that's called Al-Anon.
Right.
It's for families.
Sure.
And you go there and you have a loved one you care about who is going through addictions. And what do you do? It's a wonderful support program, and that's free.
Yeah, it's helped me.
That's good. It's a very good
Al-Anon's
program.
helped me.
Yes.
One of the things that THR has is this Texas Health Recovery and Wellness Center. Tell me a little bit about this center.
Yes, this has been open for about a year and a half. I was not looking to come to work down here, but I could not pass it up. This is a long-term recovery center. It is for people who cannot recover necessarily in traditional ways, but it's all numbers. If you do a detox plus day hospital plus outpatient, your odds are 25 to 40%. If you come here for a month, your odds are 50 to 60%. That's 1 year. You make the first year, your odds go way up. This is a very thorough program. We detoxify people, get them on proper medicines, work on emotional growth, spiritual growth, physical health. We get them in traditional recovery systems. We do group therapy, do family therapy. And it's a very calming setting. Of course, people here and they're not calm because once they quit using, there are conflicts under the surface. So it's an intense treatment program.
Yeah, it would have to be, wouldn't it?
I'm very happy to work here. Yes, it's very, very intense work.
How do we work our way through this epidemic?
I'm going to treat the patient in front of me and hope that there is wisdom and the powers that be to start doing some smart moves, which are maybe the people in government would disinvest their money from the people that sell opiates. Maybe we have a little stricter rules about what we import from China. We need to do something about the drugs coming across the border. And don't just arrest people and throw them in jail. I don't necessarily agree with the Portugal plan, but it works. You know, they decriminalized all drugs, and they put every penny that they're putting in law enforcement, they put in treatment, and their percentage of users have gone down.
Interesting.
Something to think about.
Much smaller country.
And a narrow population, but by taking all the money out of enforcement and punishment and putting all the money into treatment, their percentage of users have gone down. They're saving money and fewer people are addicted.
Doctor, thanks for your time.
Well, thank you for asking me. I'm just very happy to be here.
Very interesting subject, and you're really good at discussing it.
Oh, thank you very much.
That's going to do it for today. Dr. Gary Malone, thank you for joining us. I really appreciate this time. Texas Health, by the way, is partnering with you for a better North Texas. To hear more Wellbeing DFW podcasts, visit our website at texashealth.org/podcast. I'm Scott Sams. Thanks for being with us.